screen sharing?
Not yet, Doktor.
Sekejap ya. Okay, is it there, the slides?
Not yet, Doktor.
Yeah. How do I get the slides to be projected? It's not. Can you get the slides now?
Not yet, Doctor. Did you already open this slide in a window?
Yes, already open.
Okay. You can click the present now and then
Yes.
present a window.
I've clicked that present now and my window share. Okay, but then share my entire screen. But you didn't get it, is it?
Yes.
Was it not synced to the Google Meet? Macam susah sikit. Okay, so shall we start? Okay, did you manage to open it?
Tak boleh lagi, Doktor. Tak apa, Doktor proceed, nanti saya try.
Okay, alright.
Okay.
So what is consultation liaison psychiatry? Have you ever joined any medical officer or specialist while on call to see the case being referred to psychiatry team from other department, from other specialties? Have you come across anyone? Tak ada, masa on call tak ada sebab COVID Okay, so consultation liaison psychiatry meaning that you are a liaison specialist lah, alright? Because it is one of the subspecialty of psychiatry which involve managing cases between the line of psychiatry and other parts, other component of medicine, right? So it actually not only involve clinical service, but of course it will cater the teaching component and the research lah. So of course psychiatry, if you want to do, there are a few subspecialty to. I'm not a licensed psychiatrist in the first place, but of course when we do our general training, we have to be exposed in managing the liaison cases. All right, so almost 1 year of our training involved in seeing cases in other specialty areas. All right, so meaning that if we are doing psychiatry, our knowledge shouldn't be confined to psychiatry je. So it is good if you have vast knowledge about other area of medicine, of specialties, if we want to embark in doing consultation and liaison psychiatrist. In some advanced center, you will see that the service is being offered very proactively, meaning that the other discipline may not need to refer to the liaison team, but every day the liaison team will have their usual round in the surgical, orthopedic, or the medical ward. So later, when you got into practice, then you may come across this sort of practice lah. But of course, over here in SASMAC and HTAA, we only cater cases who is being directly referred to us lah. Okay, we don't go out and screen for all the cases because we don't have that capacity as yet. Okay, so according to Lipovsky 1983, consultation liaison psychiatry is a subspecialty that incorporates service, teaching, and research in those areas which border psychiatry and other parts of medicine. Okay, this is from Lipovsky 1983. So which main area is covered by liaison psychiatry? Obviously, it covers most area of psychosomatic medicine. All right, psychological plus soma, somatic, because we cannot easily disentangle we cannot actually delineate our bodies, isn't it? It is not actually psychological or bodily, somatic only. It integrate, so there is no health without mental health, and you know that mental health will affect the bodily health as well, so where does it take place? The consultation liaison practice psychiatry will take place mainly in hospital setting lah, in which where you get all other disciplines being offered, example medical ward, where big hospital where you have surgery, you have obstetric and gynecology, pediatric wards. Okay, so in hospital setting where all other disciplines are being offered, so that is when the liaison psychiatric service is normally required, okay, so normally the primary care team, be it the pediatric, the obstetric, gynecology, they will have referred their cases to the psychiatry, liaison psychiatry team when they have any doubts or questions about the patient's mental health, or how does the patient's mental health is affecting his or her care and treatment, so sometimes patient masuk medical ward and somehow you see that the patient start to behave abnormally, ada disorganized behavior, then they will question, okay, is this a psychotic patient in the first place? Then they will refer to the psychiatry. Or when the patient mental health is affecting the treatment they were offering, for example, when they manage the patient, they plan for operation, and somehow patient is actually not cooperating with the treatment suggested advice due to some particular reason lah. Probably they know that this patient is depressed and rejecting all kinds of intervention offered. So when they worry about some mental health issues among their patients, then they will get the patient to be referred to us lah. All right. So normally it's from the primary care team lah. Only in some places where you get to see that the liaison team go out and actively searching for the patient. They go and screen all the patient in the medical surgical ward. Itu kalau dia memang tak sibuk lah dekat klinik dia, ward dia tak cukup patient. So that's why they can offer such services. Alright. So most other these are the common issues that arise. Okay, selalunya kenapa the patient being referred to the liaison team mainly involve, the first one is capacity to consent to the treatment. Sometimes there are times where you will get to see patient where patient not able to comprehend or understand or not able to give consent to the suggested intervention or treatment, kan? So and you may doubt that the capacity is dubious, meaning that if a normal person would agree to certain such intervention being offered, but to this patient, probably the managing team that worry that patient is having dementia or patient is having psychotic illness, so their capacity to consent is questioned. So that is when they will call us, okay, in the liaison psychiatry, so that we can assess whether this patient can actually give consent, kan? Consent is valid or not. All right. So because if we think that patient had lost their mental capacity due to severe dementia or severe psychosis, then the consent should actually be taken from other legal custody lah, kan? The parent, the spouses, all right. Second issues that arise during referral probably because there are conflict with the primary care team, kan? So conflicting issues with the primary care team, kan? So sometimes patient got admitted to medical surgical ward, but the mental health component or the psychological component within that patient outdo or outplay the main problems being addressed or being managed by the primary care team. Okay, so there are conflictual problems arises in the management which need some form of psychological or psychiatric intervention. All right. The third issue is probably when there is intersection of the problems in both physical and mental health. All right, as well as patient who may report physical symptoms as a result of mental disorder, kan? So you see, those who have done psychiatry, kan? Most of you have done psychiatric posting. There are lots of psychiatric condition or diagnosis in which your patient will present with physical symptoms, kan? Physical manifestation, and also the others, vice versa. Maksudnya, some of your patient can have physical condition, but they presented with neuropsychiatric manifestation, kan? So macam your epilepsy patient, okay, for example, they can presented with anxiety-like symptom, panic-like symptom, kan? Temporal lobe epilepsy. So we may end up misdiagnosing the patient as anxiety disorder, kan? Panic disorder. A lot of medical surgical condition which may presented with neuropsychiatric manifestation, kan? So if we are not being thorough, then we may end up diagnose that as primary psychiatric problem lah. All right, so that is where the liaison services is much needed when there is intersection of problems in both physical and mental health, kan? And then you see in psychiatry, some of the patient is actually having psychological problem, kan? Macam conversion disorder, but they presented with physical symptom, kan? They come to you with weakness, for example, kan? Okay, hemiparesis, they come to you with blindness, okay? But when you check, oh, it is actually originated from the psychological component, kan? As you see in conversion patient with somatoform disorders, right? All right, so those are the three main issues arises during the liaison referral: capacity to consent to treatment, conflict with the primary care team, and the intersection of problem in both physical and mental health. All right. So what are the characteristics of psychosomatic medicine? All right, normally it studies the correlation of psychological and social phenomena with physiological function. Okay, it studies correlation lah, because a lot of findings are correlated. For example, you see that a lot of diabetic patient actually is depressed. All right. Because of the direct effect of the diabetes itself. All right. Suppression in the HPA axis, kan chronic diabetes. Later on, patient develop depression. All right, and depression itself can cause a patient to be more susceptible, more prone to develop diabetic, for example, kan? So there are a lot of correlation. And then, psychosomatic medicine also focus on interplay of biological and psychosocial factor in the development, in the cause, and the outcome of all diseases, kan? So, yes, a lot of when you manage your patient holistically, kan? If you don't look you don't label the patient according to which ward they are admitted, which discipline, which specialty area they are being treated. Then you can actually look at bigger picture, holistic approach to your patient, in which you can see the interplay. It's not only organic causes, biological causes, but normally your patient, how they present to you, how they react to your management, to your intervention, it is much related to their psychosocial factor as well. Kan? So sometimes the disease is not severe, it's not serious, but then the effect, the behavioral reaction that your patient create in the ward may actually hinder the proper management being offered to them. Kan? So all those need some form of liaison management, liaison person to address these psychosocial factors. All right. And of course, the other important objective of liaison psychiatric service or psychosomatic medicine is to advocate for the biopsychosocial approach lah to the patient care. Kan? Okay, I remember that before I do psychiatry, we always treat patient on which discipline, which area that the patient present to you lah kan. Kalau tulang tu you concentrate kaki je. Couldn't bother much about other psychosocial factors. Only when I do psychiatry that I approach patient wholly through this biopsychosocial approach. It is always fulfilling for both the patient, the relative, and you as a treating doctor when you manage your patient as a whole. All right. So how does it made the referral consultation liaison psychiatry referral? How was it made normally? Okay, so actually it depends on how you offer in your setting. It differs from different setting. So normally when we get the referral, liaison referral, we have to establish the urgency of the consultation. Kan? Some of it we will review immediately. Okay, if it is emergency, then we will review it immediately. Sometimes patients still in emergency department where the causes, the root cause is not been able to establish, and when we go there, we can offer some form of opinion on how to properly manage such patient kan. Or whether the referral is routine kan. So kalau macam just referred for depressive symptom already there for a few months, then probably we can have a thorough assessment in clinic kan. So we may see them not that immediately within 24 hours. Okay, so urgency, we establish the urgency of the consultation. All right, so commonly in terms of this referral, the request for psychiatric consult will fall into several general categories. Okay, the first one would be if a patient is suspected of having psychiatric disorder kan. So when the primary care team see the patient and they think that, and they suspect that this patient could have had some underlying psychiatric disturbance or any psychiatric history in the past or any use of psychotropic medication. So at that point of time, they may ask us to evaluate their patient, kan? Be it in the surgery, in the op-gyn, in the medical ward lah. Then they will call us. Secondly, the request for consultation is when the patient is acutely agitated, kan? Because it will disrupt the environment, the ward environment, kan? In medical ward, for example, if you just have one disturbing psychotic patient, then obviously it will just disrupt other patient as well, kan? So acutely agitated patient, then normally they will call us up immediately. Thirdly, why is it they refer for liaison? When the patient expresses suicidal or homicidal ideation, kan? So because that is obvious sign of imminent danger lah, in which sometimes if you have your medical ward in level 7 or level 8, that could be very dangerous, kan? Quite often you have read in the news, patient jump from the floor, right? From the 8th floor, 7th floor. So the moment you review your medical patient, surgical patient, and you patient did express about suicidality or even homicidality, then of course you need to refer the liaison team. The fourth referral should normally involve the high risk for psychiatric problem by virtue of serious medical illness, kan? Sometimes you may be managing a terminally ill cancer patient, kan? Stage 4 breast cancer, stage 4 uterine cancer. So patient is very depressed, okay? Patient start opposing to your treatment. So high risk. Patient looks like they are going to be having adjustment disorder or even major depression, or they can end up having delirium, kan? So you may refer to liaison team. The fifth reason, if the patient themselves request to see a psychiatrist lah. Okay, sometimes that quite often nowadays that the patient requests because of some issues that they are having, especially when they were diagnosed with some serious medical illness or surgical illness, they are not feeling all right, and they actually have a right to request to be evaluated by a psychiatrist. And then the sixth reason of referral, normally when it involves medical legal situation. Tadi we have discussed kan, the capacity to consent. Sometimes your intervention will involve major operation, kan? Nak laparotomy ke, nak apa, craniotomy ke, kan? So head surgery. So and then you think that patient not actually comprehend the procedure that you are explaining, kan? You doubt about their capacity to give consent. Memang nampak patient ni dah very elderly, macam demented sikit-sikit. So medical legal situation, then you may consult psychiatry, kan? Ataupun kalau pediatric obstetric gynecology case, sometimes cases where you have young mothers, kan, pregnant, young single mothers, 12 years old, 11 years old, already pregnant, kan, no father, and then there is decision for termination of pregnancy, kan. So normally not only that the obstetric gynecology, the ustaz, the pediatrician, the parent is involved, the psychiatric team also, they will be called up for the meeting. Seven reason is evaluation of patient with known or suspected substance abuse, kan? So sometimes patient come in and out of the medical or surgical ward because of complication of drug-related behavior, kan? Substance abuse. So sometimes that is when a liaison psychiatric service is also sought after. All right. Okay, this slide actually chart showing psychotic symptoms. Mainly ada past positive psychiatric history lah. Almost 50% ada positive psychiatric history in the past. So normally they will refer again to us. Okay, if patient still have the illness or patient already stop the follow up and medication, so they will just ask us if patient is still in need of further follow up and management with us. Other main issues is, second one is psychotic symptom, reason of referral because of psychosis. And then other reason lah, legal reason, okay, no organic basis of the symptoms kan. Patient conversion tadi, dah examine semua, neurologically is fine, normal, no finding, then they will suspect some form of psychological causes for the physical symptoms. So that is when they will call us up, okay. By the way, have you managed to see the slides or tak ada slide ni?
Nampak.
Yes.
Ada Alright, okay, good, alhamdulillah. Alright, so what are the common symptoms, common psychiatric symptoms that they refer? Yes, favorite one depression lah kan, because you see that sakit ni ujian kan, so sometimes when diorang sihat, tiba-tiba kena sakit kan, admit to medical surgical ward, diagnosed with severe chronic illness, diagnosed with cancer. So obviously they tend to be depressed kan, even kalau you tengok the grief reaction kan, denial, anger, bargaining, and then depressed, and then baru acceptance kan. So it's a normal reaction that patient can have, depressed mood kan. So other reason, agitation, and then disorientation very common sebab kalau patient masuk ward, undergo major operation, and then patient some more having a lot of multiple medical comorbidity kan, ada diabetic, hypertension, heart disease, semua ada. And then elderly pula, and then dalam ward dah tak makan minum, very poor hydration, nutritional status. So obviously they tend to be disorientated easily kan, and then duduk dalam ward lupa berapa hari bulan, hari apa, tak ada jam, so confusion, of course they can have delirium lah or dementia, disorientation, so they will refer to us. Hallucination, yes, sometimes they have psychotic symptom. Anxiety also common symptom. Sleep disorder, yes, even you pun, kalau you and I lah kan, sometimes kita bila tukar tempat tidur, you can have sleep disturbance. So some of them warded 2 weeks in the ward and cannot sleep at all at night kan, and then at up point added more problem some more is frequent checking of the vital signs by the nurses and the student lah kan. Baru je nak lelap, ada orang nak check lagi BP, heart rate semua, okay. And then other symptom is suicide attempt or threat kan, tiba-tiba dia threaten nak terjun, threaten nak strangle dengan bedsheet, so they will refer. And behavioral disturbance lah, sometimes they started yelling, shouting, paranoid in the ward, so paranoid to the staff, paranoid to other patients, so that is when they will call us up for evaluation. Alright. Okay, no organic basis for symptoms. Okay, these are the common disorder lah in psychiatry kan. Conversion disorder, somatization disorder, factitious disorder, as well as malingering. So kalau conversion, maknanya presentation with neurological symptom kan. Patient can come to you with weakness, with paraesthesia, with numbness, seizures, or even autonomic disturbance. Somatization disorder, they can have multiple bodily complaint kan, pain symptoms, exacerbated other bodily symptoms. Somatization disorder, soma body kan, okay. Factitious, dia wish to be hospitalized, dia craving for seek role, kan? Primary gain, okay? They don't actually, they wish for attention. They don't actually want something like compensation, kan? Secondary gain, malingering, yes. In malingerer, they want to be admitted because they want to get the secondary gain. They want MC, they want to be excused from attending court case. They want to be excused from being in the barrack, kan, army police officer, kan, kalau kena denda tu dia kena tahanan semua, kan. So it's better to be hospitalized. So for factitious, they actually present with physical symptom, but it is fine, maknanya patient reka, kan, simptom tu. But it's not for the secondary gain, okay, but it's for primary gain. Alright, so these are the illness in which there is no organic basis, kan. So selalu they can end up being admitted to medical or surgical ward, but when they have been thoroughly investigated, normally they will refer to us because they found no organic basis for the symptoms lah. Alright. How about functional somatic syndrome? Kan, so kalau for gastro, banyaklah they will see patient with IBS. Kan, senok, sekok, perut, kembung, berangin, kan. So then it could be actually symptoms for anxiety disorder, isn't it? Panic disorder, or even but of course they may end up seeing gastroenterologist and they will be done with scope, kan, multiple scope, and then end up they get diagnosis IBS lah, dyspepsia lah, kan. But quite often we get referral after the patient has been had multiple doctor shopping, kan. Especially kalau panic patient macam mana, semua department dia dah pergi dah. Cardiovascular symptoms, so they end up seeing cardiologists. They have done the stress test. If they have gastro symptom, so they may end up seeing gastroenterologist. They have had their scope done. Okay. Alright. So functional somatic symptom in the border of psychiatry and medical. It could be, yes, angina, tapi still it could be panic disorder, kan. Neurology, headache, kan. A lot of patient claim ada migraine. So how do we know that this is not something related to psychological, kan. Psychological headache. Rheumatology, yes, patient datang with joint pain, multiple chronic fatigue syndrome. Okay, so they may end up seeing rheumatologist, whereas that could always reflect some form of psychological component in the symptom presentation. Gynecology, kan, chronic pelvic pain, okay, vaginismus sometimes. Orthopedic, ya, chronic back pain, neck pain, okay. So functional somatic symptoms, alright. Okay, what was the approach to the management when you get a liaison referral? Okay, first, obviously you have to identify the feature of organic disease, kan. Sometimes depending on how much exposure do you have lah in both area, kan, in medical or in surgical as well as psychiatry, because our experience is not the same, kan. So sometimes kalau you don't have any idea psychiatric exposure, so the moment you see patient come with behavioral disturbance, for example, kan, 2 days or 1 week behavioral agitation, so you pun terus ingat schizophrenia ke apa, but obviously you still need to rule out the organic causes into that, kan. Especially kalau acute presentation, how do you know that it is not subdural hemorrhage, subacute hemorrhage, kan, So there is always identification of organic disease because that one is treatable kan. Kalau you tengok ada bleed, so that is operate maknanya is treatable kan. Kalau ada chronic subdural bleed, so you boleh observe ataupun tengok kalau makin besar you boleh operate kan. So we don't simply say that it is because of psychological element kan. We have to look out for possible organic causes overlaying the psychological element. And then establish degree of insight, okay, extent to which the patient recognize psychological basis for the problem, and then the extent of which the patient wants out kan. Sometimes especially kalau you deal with a patient with chronic medical illness kan, diabetic patient dah 20 years, tapi what caused the multiple uncontrolled episode? Okay, mainly behavioral kan. Sebab apa? Sebab tak nak pantang makan, malas jaga ubat kan. So until you manage that behavioral component, manage her insight about the diabetic illness, then only you can get the patient to engage with the diabetic care kan, diabetic management, and then only the diabetic got well controlled kan. So that is how you manage the patient as a whole kan. Determine the appropriate intervention program. So normally we don't become one dimensional. Selalu kalau physician they just focus on the physical lah kan. But it is always good to have multidimensional, maknanya multiple intervention, okay, multidisciplinary approach kan. Not only, okay, if you are stroke patient, not only that you manage the weakness, the physical complication, the psychological also should be addressed kan. Characteristic of effective psychiatric consultation. The first one, you should talk to the referring team kan. Be it the physician yang refer to the MO, the houseman, the nurses and the other staff before and after the consultation. So the next time around you become a houseman or junior medical officer, when other specialists from other team come and see the patient, so come and join lah. Let's just join and see kan the patient together, because your input is valuable, all right, to the liaison team to get to know the patient in depth. Okay, so kenapa? Sebab we want to clarify reason for the consultation kan. So sometimes bila kita tanya kenapa refer, sometimes the houseman ni dia pun blur. Dia pun cakap okay, specialist suruh refer. So tak boleh lah, we want to know why is it that the patient is referred. Sometimes I have had referral that mak yang tak sihat, but it's in the pediatric ward kan. Tapi the patient is actually the child patient, but somehow they refer the mother kan. So we have to know what's the reason, because the mother is not the patient here kan, unless if you are involved factitious disorder by proxy kan, Munchausen syndrome, and then okay lah refer mak dia. So we want to know what's the reason of consultation. If not, the referral may not be necessary kan. And then establish level of urgency. Tadi I dah discuss. So kalau yang urgent, tengok terus. Kalau dah 2 months symptom, 6 months, then probably at clinic setting. Review chart and the data thoroughly kan. So sometimes you kata patient agitated, confused, disorientated, tapi tak bagi tahu pun the latest blood investigation, the result, tak buat pun the electrolyte, the total white. So all those need to be presented, need to be reviewed kan. Perform complete mental status examination, okay, and relevant portion of history and physical examination. So of course dekat mana-mana pun you have to do this lah, MSA, proper physical examination and the good history Obtain medical history from family member and friend as indicated. Alright, sometimes when you get to interview the collateral history from the family, then you get much more. Okay, you have to make note, jot down. Sometimes it's a good learning exposure to both party. Kalau you review patient dekat medical ward, you tulis properly what are the psychiatric evaluation has got, and then what is your suggestion, kan? So it is helpful to the primary care team to learn about the patient themselves, okay? Alright. And then arrive at tentative diagnosis. So normally you can get immediately what is the diagnosis here. Sometimes you may differ for some time, the diagnosis until you get collateral information. And then you should formulate the differential diagnosis and recommend diagnostic test. Kan? Sometimes the primary care team ni dia refer, tapi all the relevant investigation they haven't do completely, kan? So kalau sebab you tahu, okay macam dementia, okay you nak rule out, okay probably infective causes, and then they haven't screen for that. So you can suggest lah nak screen apa dia, kan? Has the knowledge to prescribe the psychotropic drug and be aware of their interaction. Kan? So sometimes patient dekat medical ward ni dia dah ada 10 ubat dah. Dia dah ada 3 untuk hypertension, diabetik, jantung dia. So and then you pula nak start dia antidepressant ke antipsychotic. So you have to have some degree of knowledge about drug-drug interaction. Okay? Kalau you tengok dia punya liver function dah tak normal, then probably you have to adjust lah which medication is more appropriate, more safe for the patient. And then you have to do specific recommendation, okay, which is brief, which is goal orientated, and then tak payahlah guna psychiatric jargon sebab the primary care team dia orang lost juga, you nak guna term pelik-pelik kan. So better give a brief plan, okay. Discuss the finding and recommendation with the person who refer to you, kan. Make sure that the message is relayed to them. Kalau tak guna, you tulis panjang-panjang, kadang dia tak baca pun your plan, kan. So make sure that the communication is clear and concise. Alright. And then follow up patient, okay, until they are discharged from the hospital or clinic, until the goal of the consultation are achieved. And if necessary, kalau nak kena jumpa lagi outpatient, then you do that, okay. And then doesn't take over the aspect of patient medical care unless asked to do so, okay. Selalunya you have to be clear about the boundary lah. Kalau memang patient, kalau case medical, you jangan pula nak overrule. Let the medical manage their medical issues lah, okay. Follow advances in other medical field and is not isolated from the rest of medical community. So kalau nak buat liaison ni, nak ada effective intervention, you pun kena up to date lah with whatever that your surgical colleague or your physician colleague is doing, kan. Nanti barulah you tak blur apa intervention, apa operation diorang nak buat. Okay, so this is the pattern of liaison care lah. So kalau dulu patient consultant, the consult traditional setting. And then another pattern, okay, primary care physician consult patient, ada input dia consultant psychiatrist, kan, liaison psychiatry. Ataupun the third model tu, primary care physician boleh ada two ways interaction dengan patient, two ways interaction with the consultant psychiatry, or patient dengan liaison psychiatrist pun ada direct two-way interaction juga. So you decide which one is feasible at your setting, kan. So psychiatric disorder in medical setting, as many as 30% of patient have psychiatric disorder. So banyak kan, kalau you ada 10 patient dalam ward, so 3 of them may have psychiatric problem, alright. 2/3 of patient who are high user of medical care have psychiatric disturbance. Obviously, yeah, 2/3 of them can be delirious, kan. So or depression. Delirium detected in 10% of all medical inpatient and over 30% in high risk group. So kalau patient dalam ICU, patient dalam high dependency ward, so the more percentage, more prevalence of delirious patient. Cuma you nak manage ke tak nak manage, itu saja kan. You nak refer tak nak refer, itu je. Presence of psychiatric disturbance is associated with increased hospital length of stay or increased medical readmission rate. Betul lah kan. So because you have to manage the other comorbid. And then only small subset of patient is currently being identified. Sebab the service pun is not that 100% offered, depending on which setting that you are working. Her percentage of patient receiving psychiatric consultation varies from 1 to 10%. Kan? So there is great disparity between amount of psychiatric pathology that exists in medical setting and that which is identified by medical staff. So this is memang understood pun, because the number of psychiatrists is very much lacking. Even to cater patient yang ada psychiatric illness per se pun tak cukup. So what more we want to extend our service in other field lah kan. So hopefully in future time you all kalau ada minat nak buat psychiatry tu can venture into this. Now in Malaysia we are also setting up our consultation liaison team. So later on maybe we can have our subspecialty training for the liaison psychiatrist pun dekat Malaysia je. So what is the psychiatric differential diagnosis in medical setting? Okay, psychiatric presentation of medical condition, psychiatric complication of medical condition, psychological reaction to medical condition, and medical presentation of psychiatric condition, medical complication of psychiatric condition, and comorbid medical and psychiatric condition kan. So sometimes you all yang last kali ni lupa. Kalau patient tu dah ada psychiatric diagnosis, so dia tak boleh datang sebab reason lain dah. Boleh je kalau for your patient is a schizophrenia patient, they still can come to you with heart attack, with uncontrolled diabetes, with toothache, because sometimes refer sebab apa patient sakit gigi, tapi sebab dia non case schizophrenia, so panggil psychiatry. So it's nonsense lah kat situ kan. Tengok chief complaint kan datang sebab sakit gigi, so refer dentist lah. Alright. So they can have the comorbid. Okay, good. Follow up, at least daily follow up should be considered for several type of patient. Kalau those patient in medical ward, you ask them for restraint, and then of course you have to review them daily lah. Patient is agitated, patient violent, patient suicidal, okay, so should review daily. Patient delirious, patient is psychotic or not stable, or patient ill patient started on psychoactive medication. Sebab you nak review kan, if there is any problem with the medication that you have initiated. So you kena tengok lah. Intervention, psychotherapy. So nak buat liaison psychiatrist, kena pandai psychotherapy, because most often tak perlu guna ubat sangat pun. So a lot of psychotherapy work you'll be doing with the patient. So the modality introduced should be primarily selected in response to the patient's need. Okay, tengoklah kadang you perlu bagi supportive therapy je, so patient ventilate je. Kadang you need to do some form of behavioral therapy kan, behavior modification. Sometimes kena buat cognitive therapy sikit. So no single psychotherapeutic modality will be effective with all patient all the time in medical setting kan. So tengok which one is you have to be flexible, which one suited the patient most. Pharmaco and other somatic therapy, okay, only 35% will recommend medication. 10 to 50% of patients require reduction or discontinuation or psychotropic medication. So selalunya patient ada adjustment problem, very short-lived punya symptom presentation. So that's why tak perlu lifelong medication kan. Appropriate use of pharmacology necessitate a careful consideration of underlying medical illness, drug-drug interaction and contraindication. So sebab liaison service, so meaning patient ada other health issues kan, medical diagnosis, obgyn, surgical. So of course you have to look into that lah. Okay, nak discuss ni case. Dr. Nizam dah masuk ke belum? Hello. Assalamualaikum.
Assalamualaikum Doktor.
Actually,
Dr. Nizam already told us that he will enter at 3:15.
Oh ya ke? So lambat Alright. So I boleh lah. Okay, so kita discuss.
That is for about 4 minutes left.
Apa dia?
About 4 minutes left.
Oh, okay, 4 minutes left. Okay, so maybe kita tengok case satu je. Boleh lah, sempat lah laju-laju je Okay. 66-year-old lady underlying chronic renal failure, uncontrolled diabetes, hypertension. So she came in with poor oral intake and fever. So you treated as sepsis. So referred for liaison for behavioral agitation. So assessment apa yang you nak dapat ni Poor oral intake, fever. So history you nak tanya apa? Apa diagnosis ni you nak go for ni? Delirium kan? Sebab renal failure, uncontrolled diabetes, hypertension. So you nak tengok delirium lah. Dia pun poor oral intake, ada sepsis. So all the causes of delirium. So history apa nak tanya? So obviously you nak tanya about cognitive symptom lah. Any fluctuation of conscious level kan? Pagi sedar, petang confused, tak ingat waktu, tak ingat hari, tak ingat orang. Okay, history. And then any pre-existing history of dementia kan? Okay. Lepas tu any history of fall, takut ada stroke kan? Recent stroke sebab dia uncontrolled diabetes, hypertension semua. Okay, and then ada fever kan? Berapa lama fever, semua you nak tahulah all the history to diagnose the causes of the delirium. Alright. Physical examination, MSE, of course you need to do thoroughly lah kalau you suspect ada stroke. Then check lah all the neurological. MSE focus on the cognitive assessment kan. So you tengok dia orientation, especially is it patient disorientated or not. And then investigation, apa you nak buat? Of course you nak check lah dia ada fever, nak tengok total white, uncontrolled diabetes, hypertension, you nak tengok dia punya sugar level, dia ada kidney problem, you nak check dia punya creatinine and all. So all the points leading towards the delirium kan. So probably your diagnosis delirium secondary to apalah, uncontrolled diabetes ke, sepsis ke, whatever that you manage to get from your assessment. Management, of course, kalau delirium you manage the cause lah kan. You manage the cause of the delirium. Alright. Case 2, 34-year-old housewife with PhD, and then dia datang with 1 month history of lower limb weakness. But then when neuro team assess, tengok dia tak ada localizing sign kan, no point of any organic origin, and then finding pun tukar-tukar, inconsistent kan. So that's why they refer for liaison. So in your history apa you nak assess, of course you akan correct the psychosocial history banyak-banyak kan. And then end up you dapat lah the stressor, rupanya ada konflik dengan mak mertua ke, dengan husband ke, dengan boss ke. And then you notice lepas you bercerita semua benda tu, somehow symptom boleh improve. Physical examination, MSE samalah diagnosis. So kalau datang with neurological symptom, physical symptom macam ni, causes dia psychological, then diagnosis should look for some conversion in there lah. Okay, conversion disorder. Case 3, AMI. Okay, presented acute behavioral changes 1 month, disinhibited, disorganized speech. Diagnosed as schizo in district hospital, sent for admission via ED, referred for further evaluation. Okay, so AMI acute changes. So apa dia nak assess ni, history. So 1 month, yes, you have to entertain causes for both lah, psychosis and organic kan. So it could be 1 month brief psychosis or schizophrenia form, or kalau strong history about substance still cannot rule out substance kan. So kena check semua substance. Or kalau you tengok dia ada underlying medical illness, still it could be organic causes kan. Maybe ada stroke ke, ada bleed in there, alright. So you still have to work out on the possible etiology, alright. And then barulah you give the probable diagnosis. Okay, so conclusion, you should have thorough assessment, multidisciplinary engagement, and holistic intervention, alright. Okay, thank you. Ada soalan tak? 3:15 Any question? So sorry I have to go very fast sebab kita start lambat tadi. My apology for the technical problem in the beginning. If there is any question? Tak ada soalan you all ni. Faham ke tak faham ni? Ada Fitria ada soalan? Aklan ada soalan? Okay Alright lah, so maybe Dr. Nizam dah ada ya? So if then we will close with surah Al-As and tasbih kifarah. Ke ada soalan ni? I tak nampak pula. You ada type apa-apa ke? Tak ada Okay lah. So if then, okay, get well soon. Okay, thank you very much. Okay, alright. So we close with surah Al-As and tasbih kifarah. Assalamualaikum warahmatullahi.
Waalaikumsalam. Thank you, Doktor.